The NICU is its own beast. The NICU is a totally different world from the rest of the hospital. Babies are so tiny and fragile. Their sleeping arrangements are different. The care is different. It's round the clock. So much care goes into the babies when they're in the NICU. I think it is important if you can, if your baby is in a position where you can help with the cares, diaper changes, feedings, skin to skin, even just being there. My daughter, I couldn't do skin to skin. I couldn't hold her. I couldn't do any of those things. She was too fragile. But I could stand there and just put my hand on her back. And I feel like that was good for my mental health as a mom, but it was also good for her just to know that she wasn't alone and to be able to feel that human touch. When I was able to hold her, I feel like there was already a connection, even though she had never like truly met me because she was asleep the whole time. I think I was familiar to her, and I think that was important to do for both of us.
Parents get, admitted, or, the child is born and they have to face, they're in the NICU, and who would they be kind of interacting with the most? Who's on the team? Like, what can they expect?
Yeah, I think that's a very important first question for many parents. Ideally, what happens is we have some lead time before a baby that has to come to the NICU is born, and that is helpful. Then we actually go and introduce ourselves to the team. Generally, I would say the primary team that the parents will be interacting the most with is the neonatologist and the doctors that are in that team, which is usually a group of fellows, residents, and others, especially in an academic center like UCLA. And in addition to that, their point person really is their nurse, the nurse that gets assigned to the baby. Initially, if this is going to be a shorter stay, they may not have what's called a primary nurse, but when we anticipate longer course in the NICU and more medically complex cases, we do have a primary care nurse or two assigned to the family, so they are able to have this nice personal interaction with them. But in addition to the doctor nurse team that we also have ancillary services because we can't do without them. We have our respiratory therapist, occupational therapist, we have our physical therapist, we have our social worker, case manager, discharge coordinator. So it's like a pretty big multidisciplinary team that is caring for this very young, small baby.
Just while the child is in the hospital, do you have any tips for parents just how to cope with all of that?
I think it's very tough to have a baby in the NICU for whatever reason it might be. Sometimes it's a short, simple stay. They had a little bit of a respiratory issue. They're okay now. It's 2 days and we're going home. Even that can be stressful. And then we are faced with families that have a baby who's born very early at 23, 24 weeks that has to spend more than 3, 4, 5 months in the NICU. In addition to that, they have so many ups and downs. So that we understand that every day is going to be a challenge, especially in the early course of the baby. In addition to that, we also our social worker really tries to help us out in understanding what is actually going on in the family, right? Because not every family is the same. Not every family has had similar or different kinds of experiences like trauma that in their past, because that does inform the care we give to our families in the NICU. So we try to meet them where they are and try to encourage them towards taking care of their baby, again, when they can. We don't want to force them into something that they may not be ready for. Let's just take skin to skin care, for instance. There may be a mom and dad who are ready to do that ASAP. As soon as the baby's born, they want to put their baby to skin. But there may be other families who are too scared, too nervous, and me talking about skin to skin care might make it too much for them. And so we don't want to force something that they're not ready for yet. And that's where our social workers and bedside nurses are very, very instrumental in making sure that the parents are getting ready towards like being part of the care for their families. I would say taking one day at a time is the best way to deal with this. it is very overwhelming knowing that you have given your baby is having all these complex medical problems, and you don't know when you're going to take your baby home, not knowing that, not knowing what they need, not knowing if they even will survive the NICU, is a lot. So I think taking that one day at a time, and our goal is to meet them where they are and move them to the next step and optimize care for their babies. That's what we try to do. I know it's easier said than done. I'm not saying this is a simple, easy process. It's a very tough situation to be in, and the loss of control many families feel. It's they can do much for their baby, but honestly, they are just being there is the number one thing they can do. Being able to provide breast milk. I think these families, mothers are asked to bring breast milk at one of the toughest times in their lives. And they do. And that is, breast milk is, we have shown now multiple studies, again, just like Skin to Skin has shown, breast milk is big in terms of, their outcomes. Certain little things like that do matter in a big way. I think just focusing on all the positives will help them cope. Yeah.
Should parents sleep? Are they able to sleep over? Should they, sleep somewhere else, go back home? What if they're not near home? Or like food, all that stuff. How do you think parents should maneuver to be, in a healthy space?
Yeah, sleeping also depends upon each hospital and what the level of care your child is needing. So you're typically going to be ending up needing to do something like Ronald McDonald House, or you're going to need to find a hotel that's cheap or someone to stay with nearby if you're not local. Um, Again, back to the families that have been in that situation, they may know some charities or someone that has some kind of organization nearby that maybe the social workers aren't aware of. But the social workers are a good place to start. And then you can trail off and talk to other families. Socializing with other families in the family lounges is also another way to find resources. That networking is key. Um, there are some hospitals, depending upon the level of care that your child needs, that will have bedside sleeping. And I think that if you can do it, I think it's important to be there, because you never know like what your child needs in the middle of the night. If they're going to have a new staff member that doesn't know your child and you need to explain things, they have questions, etc. It could happen at any hour. And so being close enough to be able to intervene and offer that information, I think is important. Plus, you can be there to cuddle your child. It also helps with you and your mental health, knowing you're there and you can be there and help them and cuddle them and take care of them when they're so sick. I think it helps. But that being said, you do need to take time for your own mental health and take a break, get out, breathe, recharge. And you should never feel guilty for doing that. They are in hospital. They do have people caring for them. They should be safe. For you to be able to go take a minute and breathe and go take a nap somewhere else, go take a shower. You should be able to do that, and you should not beat yourself up for it. You investing in yourself is investing in them.
What would you say is like your top tip for emotionally and mentally handling, whether it's NICU or just regular, but like the long hospital stay?
I think building a support system is the most important. If you know your baby before they're born, if you know that they're going to be spending time in the NICU, start building that support system now. We didn't know that my daughter was going to be in the NICU. We didn't know that she was going to be so fragile. So we did not have time to build up a super strong support system. So that came after, but it can be done. Um, I think having families who've been in that situation is probably the best, because they truly get it, they truly understand, and they can talk the medical talk. They can talk about all of the things you're seeing without you feeling bad or guilty. Whereas I think a lot of times friends or family that haven't been in these situations don't know what to say, and so you can feel like you can't talk about it, or you can feel a little bit guilty, like you don't want to be making them sad, so you kind of clam up. But other families who've been through it can help you process all of that, and talk through it. So I think that's important. talking with the staff. I've been friends with some of my daughter's nurses since she was born. I'm still friends with them because they've seen all of this before, and so talk to them, ask them questions, get to know them. They're taking care of your baby. Might as well. They're going to be there for their whole shift. Um, might as well get to know them. I've built my support system with other families, with my current family and friends that I had before, new family and friends, medical professionals, therapists. I mean, anyone can be part of your support system. It doesn't have to be a certain way. There's no cookie cutter for building a support system. You just need people in your life that will be supportive, that will let you talk, that will be there for you. That's what's important. And that's huge for your mental health. Therapy is also huge, but a lot of times when your baby's in the NICU, you don't have the time and you will put it off. So it's important. And if you can do it, I suggest you do it at some point, whether it's right now while your baby's in the NICU or if it's later when they get home, but make it a priority and process all of that trauma. Just
Okay.
walk around the hospital, just leaving the room, because it really does feel like a jail cell sometimes. You're just in this small room. You may not even have a window. You have a very uncomfortable bed. You're not sleeping regularly. You're not seeing the people that you normally see. You're not able to just go do what you want to do all the time. So it can feel extremely isolating. So even just getting out of the room, I would just walk around the unit sometimes. Just walk around the unit. You don't even have to leave the unit. Just walk around, get moving, say hi to people, see some other human beings smiling. Um, that can be huge for your mental health. Just walk outside, or get some fresh air, and then come back in. Anything, 5 minutes, and it'll help.
So once the families are kind of settled and let's say they have to be there for a very long time, I guess it's hard for them to be separated from the child, if they're having to go home. What is the best way for them to continue being involved in the child's care?
But when they go home, there's many ways that they can participate in the baby's care. I would say, depending on how they're feeling physically and mentally about things, that's the first thing. They want to make sure they are doing self-care before they start, being able to do more for their baby. We do actually encourage family-centered rounds. We like them to be participating in rounds. Sometimes we have them call in while we're rounding on their baby. Sometimes they're there physically, when a few weeks down the line, they do feel better and they're able to join rounds and they don't have other commitments. They do come and join rounds with us. We actually ask for their input if things are going the way they are hoping or expecting, or if we're having challenges, we let them know why we're having challenges. Our parents are actually allowed in our UCLA NICUs to be in the NICU at the bedside for pretty much the entire day. There's only, I think, a few hours, an hour in the day when the sign-offs are happening between the nursing teams. Shift changes is the only time they may step out, just because of confidentiality and things. There's so many babies in one little pod, so we just probably step out for a half an hour during that time. So that's our main one. We start with having them get included in the care of their baby and the sort of the plans we're making for the baby.
Got it. And with like touching the baby, breastfeeding, is that encouraged or just depends on the situation?
Yeah, touching, I would say skin to skin is really forefront for us because, there's enough evidence to show now, and there's many papers that have been published to show that skin to skin care is very, very useful and helpful even in the sort of the immediate sort of outcomes for a baby, and also further, down the line, their neurologic and developmental outcomes. So we do try to encourage skin to skin care. Obviously, we understand that sometimes the baby is not very stable yet to be, taken out of their incubator, put on the parent's chest. But if that is the case, we allow them to do more of the touching, containment, and other things that the nurse and the therapist teach the parents to do. They can do other things while we're still waiting for this whole lot of hands-on care. Like they can read to the baby. We encourage singing. We try to get music therapy involved as well, like so that they can do some things. Once we are able to start touching the baby because they're more stable and they're doing well, we actually encourage the infant massages. We have a massage therapist that can come and teach you, especially our therapists are the ones who teach them to do that. We actually want them to start doing daily cares, like, doing diaper changes, maybe start giving them a bath or things like that. When they're in a place where they can start taking oral medications, we actually start encouraging parents to start doing that as well so that they feel comfortable doing this. We also want them to start learning to do the different kinds of exercises a baby should be doing, because as you can imagine, these medically complex babies, you're probably scared to touch them sometimes or maneuver them in ways you would do a typical term baby who's at home. So we want them to start being able to get comfortable with that process. So we start that as early as we can.
Parent education and training. So does that happen before they leave the hospital? Just like the machines, the medication, like all of that things that they need to know to do at home. How does that happen? And how can they take advantage of it?
Yeah, yes, I think our goal is to make sure that everything from the basic care of a baby to safe sleep to whatever complexities the baby may have, medications, equipment, oxygen, feeding tubes that they may have to go home with, everything happens in the NICU, and that they are comfortable doing it before they go. Generally, I would say this is something that our discharge planners start thinking about very early on. And then we right around closer to discharge, we make sure the equipment has been delivered to their homes. And then because these equipment generally are not the same as the ones that are in the hospital, they're different. So we want to make sure the parent is familiar with using these equipment. Even a simple giving medication like multivitamins and iron, we teach them, because babies don't take medicines easily and well. So we want to show them that. We show them how to use the feeding pump, for instance, or how to use the oxygen machine. We also have reps from these companies that are providing these equipment come and teach them along with a nurse, the bedside nurse. Generally, it could be anywhere from a few days to a few weeks process to try to get them set up and ready to go. So it's not something that happens in a hurried way and they're out. We want to make sure they're working well. In addition to that, our discharge coordinators actually reach out to the families after discharge a week or two, just to make sure it's all going okay and they're not having, facing any challenges with that as well. Yeah.
What should a parent's discharge plan be? Order of operations? Like, what should they know in this process?
This is a very important question or sort of set of things. I feel like what probably parents don't realize, or it's surprising to hear, that we start discharge planning on the day the baby's born. So baby comes into the NICU. We have weekly multidisciplinary discharge planning rounds. That's exactly what it's called. It's run by our discharge planner or our discharge coordinator. We start anticipating the baby's needs right away. Again, this depends on what their needs might look like down the line, because they came with this congenital heart disease, or they came very early, like 4 months early, or they have a brain issue that we have to take care of. Whatever that is, we kind of start anticipating that literally on day one. In these weekly meetings, we talk about the need for follow-ups, referrals, we need for different kinds of medications, particularly the ones that need prior authorization. So we have them there before, well before discharge, so we're not like delaying discharge in any way. We talk about the equipment needs, what challenges we're facing with getting these equipment, and what the timeline will look like for the equipment based on the different insurance companies and other things. And in addition to that, the discharge coordinator actually starts meeting the family periodically to sort of set them up for what this is all going to look like. Hey, your baby's going to go home on oxygen, and he's going to go home on a feeding tube. So obviously we want to make sure your home is set up for all this, to make sure the power doesn't get shut down in your house, or you have a backup generator when you need it, if especially a baby's going home on a ventilator, for instance. and they talk about, different kinds of medications that need to be given, the referrals that are going to happen. We also try to set them up if they have many different follow-ups that are going to be ongoing for months. We actually try to get them into what's called a medical home. The medical home then coordinates these visits in a way that they're not going every single day to some visit, but they're able to bunch visits in a particular day or two in the week. This way, there's a little bit of, sense of normalcy for the family. So it's a very, I think it's the toughest job to be as a discharge coordinator in NICU, because you're anticipating the needs of the team, you're anticipating the needs of the family, and potentially what challenges, you face in the community as well.
What do parents need to do if their baby's going home on medical equipment? I mean, I think said everything is generally ordered beforehand.
Yes.
And the doctors, so would they have to be ordering anything, or they would go home knowing like when to do what, where to call, like that would all be set up for them?
Yes, everything. I think what we start with first, making sure the equipment gets delivered way before, the actual discharge date, so they can get trained on it, understand all the ins and outs of it. Usually the rep who drops off the equipment has a sort of like a what you call those hotlines or things if things are going wrong or happening. We generally like to get in touch with their primary care pediatrician who's going to be caring for this baby. So our goal is a few things. One is they get the training, we get the equipment, we get all the follow-ups and referrals done. But honestly, I think the one big thing we need is who is going to be following your baby down the line, periodically looking at your baby, making sure you're making these referrals, making sure you're getting to these follow-up clinics, making sure you have more equipment and supplies, because we do order all the supplies they may need for the first several months, but then it's the responsibility of the primary care pediatrician. So the parents, again, our discharge coordinators help them find the primary care pediatrician. One, knowing where they live helps, because then we have different primary care pediatricians over there that can be the follow-up physician. Once they leave the NICU, the primary care pediatrician is their sort of point person for all of the rest of the care. But we always say, like, hey, if you have any questions after discharge and you haven't still established care with your primary care pediatrician, we are still your sort of point people. Please call us. We'll help navigate this with you if you have issues with your equipment or your baby or anything you're worried about.
And so one of our parents at Undivided, she is on staff, but her daughter is medically complex. She has many complex, and she said that she was rejected by a couple of pediatricians because they just didn't know how to handle a child with that many needs. Is there kind of a recommended list that is given to parents of these, pediatricians are in the know of, how to deal with it? Like, how does that work?
Yes, I think we have faced some issues where every pediatrician in the community may not be equipped to care for a complex baby. Our most babies that go home with equipment, I would say our best recommendation is to have a primary care pediatrician within the hopefully either UCLA or CH, even Children's Hospital LA is fine. I think what we need is a group of specialists who are going to be able to care for this baby, not just the primary care pediatrician, but primary care pediatricians associated with these big hospitals are usually helpful and are they get most of our NICU follow-up babies, the NICU graduates, I should say. So yeah, not everyone, it's hard to know sometimes though. I feel like we don't have much control sometimes as to who the primary care is going to be because of the insurance and type of insurance, a sub-insurance you may have, like LA Care, something else. I mean, we don't know. This is the primary care that's assigned to you. But we quickly realize, and this is where I think our discharge coordinators who continue to play a role even after discharge is making sure that this is okay. Because sometimes family come back and tell us or tell them that this is not going well. Then they make sure they help them navigate the process of changing their insurance in a way that they can get someone else. That is very true. That has happened where we've had parents, unfortunately, not had a pediatrician who may not be very familiar with the multiple things that happening for a baby. And the pediatrician in the community may not even have the resources to help these kind of families. Yeah.
Any other transition tips you would give parents when going home from the NICU?
I think I may have covered this already a little bit. I think transition tips would be sort of um, getting involved as soon as they are able to in the care of their baby from the get-go, because handling a baby that is quote unquote fragile, right, who has all these complex medical needs, is the first sort of challenge for most families, is like even like doing diaper changes, feeding that baby, giving medications to the baby. I think that is the number one thing that they want to start doing as soon as they're able to cope with that mentally and physically. Joining rounds is the number two. They're able to understand, okay, what is going on? How is my baby progressing? Again, using many of these babies have so many different diagnoses that are sort of very complex to understand. Again, we have some uh, resources for parents to learn more about them. Our bedside nurses help them learn more about the diagnoses and things, which does help them cope better with the stress of the diagnosis and what to expect with all of this. In addition to that, it actually helps them ask questions about, okay, what is the next thing that we are going to do? And hey, this is where I want to get my baby to. This is my goals of care for my baby, and we want to do that. So being involved sort of in that manner does help them to cope better with the transition as well. I think it's still very challenging. Taking a baby home that has many medical needs is very challenging, knowing that we are there at every step, and taking the advantage of calling us or letting us know they would appreciate more resources, or probably us trying to understand that they need more resources. Let's help them out with this, or let's refer them to Wayfinder or Undivided or whatever that is. I think we have to work on that as well, and I think our social workers are really good about that. And knowing that there are some families who need more, maybe a phone call or two more to make sure that they are doing okay, following up with them. We do the 1 week or a 2 week phone call. I don't know how many times because I think our expectation is once they have left us after the 1 or 2 weeks, they have established care with their primary care pediatrician, and they are their main resource for everything else. Yeah, it's a tough journey. I can't generalize it also. Every family is different. The family support that they have is different. Their own sort of adverse events in their lives shape the way they are able to cope. So it's a combo of things that we have to do to get them to their next step. Yeah. We are all working towards the same goal, and sometimes it doesn't feel that way. The minute your baby touches the NICU, we start thinking about what your baby's needs are, not just in the NICU, but afterwards. That process is kind of ongoing parallel with whatever the NICU course. And so I think that is something they need to know, that we are getting ready, even though it doesn't seem like discharge date is anytime soon. We are actually getting ready for that. So we always want to make sure that they are taking care of themselves. I think that's the one thing that most parents forget, is they want to be there for their baby, but you have to be there for yourself before you can be there for your baby. So we continue to encourage that. And we want them to know that it's okay to take a day, and let us know if that's what you want to do. And if you're involved from day one in the care of your baby, and however, like we said, sometimes you may not be able to touch your baby yet, but you're there, you're maybe reading a book or singing a song, or just sitting at the bedside, starting there to then moving on to changing diaper and giving medications, learning to do the equipment. I think we certainly are a place where we want to do family-centered care or family integrated care for a baby.
The other parents are I learned more from other parents to start off with than I did from the hospital. The hospital was great at keeping my kid alive, but the other parents were great at helping me to understand what I needed to be doing, how I needed to be asking questions, and just finding like the resources.